Yeah. Welcome everyone to another C-SPAR Spotlight. Today I'm really excited to be introducing Dr. Lauren Khazem, who is a clinical assistant professor and psychologist in the Department of Psychiatry and Behavioral Health at The Ohio State University Wexner Medical Center. Her research is focused on identifying unique drivers of suicide risk in the disability community, veterans, and military personnel, and she integrates these findings in clinical research with the goal of improving the efficacy, accessibility, and reach of suicide prevention interventions for these populations. She has served as a principal or co-investigator on projects totaling approximately $30 million in extramural funding through the Department of Defense, NIH, and the American Foundation for Suicide Prevention. And so without further ado, I will pass the spotlight over to Dr. Khazem.
All right. Thank you all for having me today, and apologies for the funny screen share situation. But we are going to make things work here. So I'm so excited and honored to be invited to speak a little bit about my work focusing on suicide prevention in the disability community. So broadly speaking, my lab, the support lab, focuses on increasing the efficacy, reach, and accessibility of our interventions to decrease disparities in suicide prevention, research, and treatment, primarily the disability community and veterans and military personnel. However, I'm going to really focus on the disability community today, thinking about the past, present, and future intervention research in this specific population. To kind of give you an overview of why I focus on the disability community, I just want to show some stats here. The disability community is 4 times as likely to have attempted suicide within a 1 year period. And we find that as the number of disabilities an individual has increases, that odds increases to 8 times as likely for those with multiple disabilities. And more recently, national representative data have shown that there are higher odds of various suicide-related outcomes, specifically ideation, planning, and attempts among the disability community at large when we compare that to folks without disabilities. And those odds are consistently at a national or a population level, around 2.5 times greater. My previous research also shows us that people with disabilities have a 3 times greater odds of having transitioned from thinking about suicide to having attempted suicide in their lifetime compared to people without disabilities. So across the board, from a more zoomed out lens, we are seeing higher rates or higher prevalence and risk of suicide-related outcomes in the disability community. I also just want to make a quick note of what I mean by disability, because I get that question a lot. What counts as a disability, I will say, varies. So my previous research is focused primarily on physical and sensory disabilities, but has also more recently expanded to include neurological conditions such as seizure disorders and traumatic brain injuries in my more recent work. But when we think about my past work, a lot of that is focused on sensory and more physical disabilities. And when we talk about disability, the focus also matters because 28% of Americans have a disability. So this makes the disability community one of the largest minority groups in the US. And we can see that the type of disability really varies, but more cognitive focused disabilities are have the most highest prevalence in the US. My previous research also consistently indicates that one mental state called perceived burdensomeness is heightened among people with disabilities. And when I talk about perceived burdensomeness, I'm referring to beliefs of being a burden to others to the extent that others would benefit more from their death than if they continued living. So in a national sample of 127 adults with physical and sensory disabilities, I expected that felt stigma or these beliefs of fears of being discriminated against due to having disability or treated poorly due to having disability would be indirectly associated with people's perceived likelihood of both thinking about suicide and their perceived likelihood of attempting suicide, specifically indirectly through that perceived burdensomeness. I also expected this relationship to be strongest for those with disability, like related difficulties in differing areas of functioning. So like a moderated relationship there. Just given that A lot of the work focused on disability has looked at the type of impairment being as seen as a risk factor for suicide itself. However, that's not exactly what I found. So you see by that red X there that um, disability-related impact in various areas of functioning might not actually be that important. There wasn't a significant moderating effect of the severity of impairment in things like economic self-sufficiency or cognitive independence, social integration into the community. I also looked at other factors such as like physical independence. So literally being able to like get to point A to point B using either like a wheelchair or any sort of mobility aid or like independently. Um, that also had no effect. But we did see, as anticipated, this indirect relationship between felt stigma and these beliefs of being or seeing suicide as more likely as in the future, or suicidal ideation as more likely in the future as well. So I also want to note there, though, that even though I found these things, that feelings of burdensomeness are a driver of suicidal ideation, but they're not different across disabilities. So again, we think about like disability type or impairment as something that is maybe a driver of suicide risk. That's not what we're finding. We're finding no significant differences also in the kind of suicide attempt history by disability types or what congenital status. So whether or not someone was born with a disability. So these mental states associated with suicidality, so like felt stigma, perceived burnsomeness, might actually be great targets of interventions. But I think what's most important here in my earlier work is that these findings are really indicating that is what's most commonly taught about just disability itself or impairment itself as a driver might actually be a misconception, and that we really need efficacious interventions that target suicide risk and these internalized beliefs in these populations that can contribute to these beliefs about suicide. I also just wanted to note, kind of we think about rethink disability and suicide. I wanted to delve a little deeper to see how people with disabilities view their bodies and how that interacts with perceived burnsomeness and whether that's just dependent on disability type itself. So what I did find is that this interaction between body esteem or how people view their bodies and perceived burnsomeness is only significant with people with vision impairments and at high levels of perceived burnsomeness only. So there is a bit of a differing effect there, and this might be partly due to what's called this hierarchy of disability acceptability within disability studies. We find that more blindness is lower, quote unquote, on this hierarchy of what types of disabilities are more acceptable in the world versus mobility disabilities. And for instance, at the very lowest kind of is like more cognitive related and developmental disabilities. So it may be that, again, it's more due to what people believe about having a disability itself and not the disability that's a driver, but more work needs to be done there for sure. Again, though, I just wanted to point out that it might be that internalized maladaptive beliefs about having a disability that includes body esteem might be important intervention targets for suicide prevention research. I identified brief cognitive behavioral therapy as an ideal intervention to target these drivers in the disability community and for future adaptation because it's transdiagnostic and it's three-phase intervention that is skills-based and it's flexibly applied to prevent suicide through skills acquisition and emotion regulation, more broadly speaking, and then more specifically cognitive flexibility or cognitive reappraisal skills. So we see in this roughly 12-session intervention, individuals learn different skills that are really kind of geared towards these areas, and they're mapped onto individual case conceptualization of deficits, contributing to each patient's acute suicide risk. With the final phase being a relapse prevention task, where the individual demonstrates through kind of an imaginal exercise their ability to use the skills they've learned in treatment to successfully navigate suicidal crises. So before I talk about applying BCBT to the disability community, I just want to give some findings on another of its efficacy and again why I selected this intervention. So BCBT has multiple RCTs now published of its efficacy, with more results coming out soon. In the initial RCT comparing BCBT to treatment as usual, or just the standard of care, what was happening in an Army clinic, we saw a 60% reduction in suicide attempts. But in those who did go on to make a suicide attempt, because it did happen across conditions, but those who did go on to make a suicide attempt in BCBT took longer. Also, more recently, my colleagues and I tested a telehealth-delivered iteration of BCBT compared to present-centered therapy, which is an active control condition. We saw, again, that there was a reduced risk of suicide attempts by 41%. And we also did this study in our most recent trial published in JAMA, where we looked at whether BCBT reduced the risk of suicide attempts again in veterans and military personnel. Whereas the one before I forgot to mention that reduced attempts by 41% was a civilian sample or a non-military sample. We saw, again, this reduced risk of suicide attempts by 76% when compared to that present-centered therapy. So we're seeing these significant reductions in suicidal ideation and depression as well across follow-up periods. But we really wanted to focus on suicide attempts here within that those follow-up periods. So we're seeing great effects for suicide attempts. And given that our previous RCTs did not examine how fast people can improve actually during the acute treatment period, I have some findings coming out soon where I looked at improvement over this period in this recent trial that was just published in JAMA, focused on veterans and military personnel. But I wanted to know, compared to that present-centered therapy, the active control condition, are people in BCBT getting better faster? When we think about our secondary outcomes, a lot of times people are very interested in suicidal ideation, suicide cognitions, depression, insomnia. So the answer is yes, that people are getting better faster in BCBT. Looking at these graphs, we actually begin to see these clear differences during the treatment period pretty quickly. We're seeing suicide ideation compared to PCT. It's actually improving by that after that first week in treatment. Suicidal cognitions are improving by week 2 in BCBT, but it takes after week 7, so over halfway through the treatment period in PCT. Depression and symptoms are improving by week 2. But again, really taking over a month longer, if not 2 months longer, if we're thinking weekly sessions in PCT. Insomnia improved in week 3 in BCBT, actually got worse in PCT. So we are seeing that not only does BCBT reduce the risk of suicide attempts, but during treatment, people are starting to feel better faster, which I think is incredibly important because having patients feel better faster really speaks to treatment engagement and lowering the risk of attrition. So with all that being said, let's talk about adapting and testing BCBT for the disability community. Had some big questions here. The first of which are, do people with various disabilities experience significant reductions in suicidal ideation, as well as those other mental states like perceived burdensomeness that I talked about when receiving BCBT through telehealth? Because we want to make this treatment as accessible as possible, and we know telehealth works. 2, what are the other changes that we need to make to increase people's the accessibility of the treatment, but also make it more acceptable to the disability community? So in this study that I'm finishing up, probably the next few weeks, actually, was funded by the American Foundation for Suicide Prevention. We pilot tested BCBT to 60 individuals with various disabilities, so physical, sensory, neurological, like I mentioned, seizures, disorders, TBI. So I'm not including developmental disabilities in this study, because I do think there may be other adaptations that might need to be considered. But I also wanted to make sure that everything was accessible and the materials we used, the assignments we used, and I'll talk more about what that looks like here in a minute. And I wanted to target emotion regulation deficits, particularly cognitive reappraisal, cognitive flexibility, types of skills or deficits that are maintaining suicidality. So I talked about perceived burdensomeness. And I anticipated that we would see a lot of movement there in the second phase of treatment that really focuses on that aspect of emotion regulation. So I wanted to talk more about this approach to rapidly refining our intervention. This is called the responsive feedback, a responsive mechanism feedback design, and it allows us to rapidly refine the intervention throughout the study. And that I'm gathering feedback in areas that I think are going to increase improvements, so decrease suicidal ideation and decrease attrition throughout the trial. I'm gathering feedback on what participants think about the materials, the homework, the intervention itself, the telehealth modality that we use. And I'm able to, after gathering that feedback from a group of participants that have individually gone through the trial, I'm then able to make those adaptations. And we're going to test whether those adaptations actually improve these study outcomes. I want people to continue to attend the sessions, and I want them to get better and get better faster. So the feedback is really guided by the participants that go through the study. And I'm currently in the last phase. So all the adaptations that patients have already, or participants have already suggested have already been made. And that the final iteration is currently occurring. But what I also like about this design is that it's used in global health intervention contexts. So these are scenarios in which large-scale clinical trials might not be feasible, or they just take a long time to really make an impact on critical problems. The idea is that by the end of this trial, which is rapidly approaching, we have a final product that's ready for larger scale RCTs, but more importantly, implementation. So we have 50 people that have, as of the time I created this recently, 50 people completed treatment with 10 currently in treatment. I think that's like down to 8 now. So we are so close. But there's a few things about the sample that I really want to highlight. Only half the sample identified as heterosexual. So from a sexual gender minorities kind of standpoint, we do have a lot of folks that don't identify as male or female or man or woman. But also only half the sample identifies as heterosexual too. So there is a large overlap in the disability community and the LGBTQ community. So I'm not surprised, but I was very excited that we are capturing a sample that is also representative of folks who do demonstrate greater prevalence of suicide-related outcomes. Let's talk about disability type. So the vast majority of folks in the study had only a mobility-related disability. So that could mean anything from any types of disability that prevents them from getting around. I've seen spinal cord injuries, for instance, to individuals with amputations, chronic pain types of conditions that they require, that they aren't able to move around very easily. A lot of people with multiple disabilities. It's very common for people in the disability community to just not have one form of disability. So for instance, someone with a vision related impairment, but also a mobility related impairment as well. And we had a number of individuals with neurological conditions, like I said, TBI, that have or experienced a stroke or have a seizure disorder. Racially speaking, I do think I would prefer to see a more diverse sample. However, I think it is an improvement compared to some of the suicide prevention research that is out there. It is a largely like 75% white sample, but a large number of individuals also identify as having being from multiple racial backgrounds. What I also want to note, I think that is another strength of the study. It is roughly a middle-aged sample. A lot of the research focused on disability is either in children or older adults, but the majority of individuals with disabilities are actually under the age of 65. So we are capturing, I would say, a sample that is more representative of the disability community in that regard. So another way of thinking about this is I'm excited to an extent that we're reaching those underrepresented in suicide intervention literature who also experience that disproportionate suicide risk. So let's talk about the current outcomes. I'm excited to share them. So When we look at the suicide for ideation scores that I assessed SI severity using the scale for suicide ideation every week in treatment. Good news is the findings are similar to what I've mentioned. I'm publishing within our within group changes or in SI during the treatment period that are unpublished by or should be coming out soon. We're seeing significant decreases in suicidal ideation scores by session 4. We're also seeing this continuing throughout BCBT. And these findings are consistent with large-sized effects, and I wanted to benchmark that against our different clinical trials. We're seeing this basically the same large size effects, maybe a bit bigger than what we found in our clinical trial recently published in JAMA, comparing BCBT to PCT. But again, we're seeing great improvements in those within subjects or within subject scores there. But I think what I really want to highlight was actually probably the most shocking thing to me is that generally psychotherapies have not so great or don't necessarily fare so great when it comes to attrition. What I'm finding is once people attend one session of BCBT, they tend to stay in. So we have 11% dropout during the treatment period. And I know that number has not changed since we've done I conducted these analyses because I check on this every week. So we're seeing people meaning they're probably generally liking the treatment as well. Let's talk about the other findings. I talked about perceived burdensomeness, suicide cognition scale scores. Again, we're seeing these reductions and these cognitive drivers in the disability community, such as perceived burdensomeness. We're seeing this happen by mid-treatment, or roughly by the time we finish phase 1, that session 5. We're also seeing these significant decreases happening again until treatment completion. So I'll note I didn't assess this every week. I assessed this at the beginning of baseline, session 5, and at treatment completion. But what's also really fascinating to me is the decreases are happening most sharply really before cognitive flexibility skills training or the cognitive that phase 2, we're really focusing on actually targeting these drivers. So it might be that more broad or different emotion regulation skills might be a larger or stronger driver of BCBT's effectiveness than cognitive reappraisals specifically. I'll note that we're finding this across studies in some of our recent analyses. So I don't think this is necessarily specific to the disability community, but it might be that people are able to cognitively restructure on their own more effectively once they acquire broadly more emotion regulation skills. And further skills instruction is just enhancing that. So again, finding really exciting findings there. And I'm seeing a bunch of questions come in the chat. I'm excited to answer those when those come about. So I talked a little bit about implementing changes based on feedback from the disability community. Let me give you just a couple of examples of that. Here are just some examples based on participant feedback in earlier phases of treatment. The biggest piece I would say that will happen in the manual is that there were some disability-focused adaptations to our sleep skills. Some of the participants, I should say a large number, really provided feedback that the sleep skills were not that applicable to them a lot of times. For individuals who are maybe stuck in bed longer or have difficulty getting out of bed. So we did, with consultation with a sleep expert and rehab psychologist, actually make some changes to the bedroom, the sleep hygiene skill, which happens in phase 1 of treatment, to make it more adaptable or applicable to some individuals in the disability community. Participants also wanted to increase accessibility of their materials. So we actually developed an online repository that lists all the materials throughout treatment in different formats and ensuring that they are accessible to folks who are using screen readers or screen magnifiers, as well as more information about the study. So that way they can use that at any time. I want to talk about next steps of BCBT for the disability community, um, and kind of what we're doing currently. So BCBT is demonstrating promise in reducing suicidal ideation in the disability community. It's also, we're seeing really low dropout. So it seems to be pretty acceptable at this time too. Working on some grant proposals for BCBT for veterans with spinal and civilians with spinal cord injuries that I will be putting in now that it seems that the funding has been restored to CDMRP this year, and that spinal cord injury program, and really focus on individuals with chronic pain conditions and their caregivers as well. I'm also focused on adapting and testing BCBT's specific components. So I have grant proposals out focused on adapting legal means counseling for individuals with neurodegenerative conditions and involving their caregivers as well, as this is a high-risk population with limited treatment options or limited adaptive treatment options. But also focused on it, I've got a grant right now working on with folks at the Strong Star Consortium focused on testing crisis response planning in military personnel with traumatic brain injuries. And in the future, I will be transitioning to a new institution where I will be testing crisis response planning in the autistic community. I also wanted to note DSPIRE, or the study was that I just mentioned, was featured in a documentary called Meandering Scars that is being shown across the country right now. I haven't seen anything in the Seattle area, but I've seen screenings Charlotte, Philadelphia. We did one in Columbus. There's been quite a few in LA. So please stay tuned as they are shopping that around. I'll actually be speaking about the experience, the Suicide Research Symposium with the documentarians. So I'm going to plug that right now if you want to learn more about that process and what that was like from a scientific perspective, or partnering with the media or documentarians to showcase the work that we're doing. So I'm excited that we're already having impact. With that being said, I know I'm finishing quite a bit early today, but hopefully let's save some time for, looks like, a lot of questions and conversations. But I wanted to highlight that this work is absolutely a team effort. There's our collaborators and support lab team members here who have made all this work possible. And of course, the funders who definitely made all this work possible. I'm very excited to continue this line of research. I think there's a lot of very exciting things happening here. So please be on the lookout. And just wanted to see if there are any questions here from our team. I'm going to go ahead and open it up to the group. See, we have some actually in the chat, so I'm happy to open those. Oh, I think just some good mornings. All right. Well, then I'm going to stop sharing my screen so I can see everyone.
Thank you, Lauren. I just wanted to say really cool work that you're doing. It's so fun to see how much additional work you've done since I remember that first review paper that you were working on, and just like how much your work has grown since then. And yeah, just very informative. And it's really cool to see the initial DSPIRE findings that you have. And I'm wondering kind of if you can kind of speak more on kind of what you think might be going on. Like, are there particular modules in BCBT that you think are particularly effective or leading to some of those changes you're seeing?
Yeah, that's a great question. So initially, I thought going in, just given my previous work, it's obviously going to be phase two, like really addressing the like perceived burdensomeness or disability-related beliefs that are in individuals, like specific suicide mode, or like individuals like really personalized, individualized beliefs that keep them stuck, re-experiencing these acute suicide risk kind of So I thought, surely targeting that is going to have the most effect. And it's not really, well, it does. We are seeing that's the case. Something about phase one seems to really work. So if I had to take a guess, just given that people are getting better quicker in other trials, I think crisis response planning has a lot to do with it. That happens during phase one. So I'm a national trainer in BCBT as well as even doing it in my clinical practice. Uh, Nobody leaves session one without a CRP done. Like that is, they need to leave with a skill. And since we're seeing people get better as quickly as phase one or other trials, I imagine, and then a lot of these skills are more general emotion regulation skills too. I would have a sneaking suspicion that crisis response planning, actually using it, has a lot to do with that. The For our participants, because it's also really individualized to the person. Our other skills that we can do during the first phase of treatment, they can be moved around a bit for person to person, but we find that since folks are getting better, like generally by session four, a lot of times those skills are going to be things like identifying individuals' reasons for living, which is also part of the CRP. It works so well in making folks feel better. We actually do it twice. So those types of skills appear to be probably the ones that are working most. And then their cognitive reappraisal skills, again, just build upon that. We find that individuals are already feeling better, suicidal ideation is going down. So the perceived burdensomness, these suicide-related cognitions that also fall in line with that. That also are actually quite predictive of suicide attempts, by the way, are going down quickly by that point in treatment too. So I think it's more, individual, broadly speaking, these emotion regulation skills that seem to be the ones that are most impactful, with crisis response planning being the biggest one. I tell patients, and I tell people I train, BCBT is really just making a really, really good crisis response plan. But it's just that we're adding more and more skills you can use as time goes on.
That's a great way of describing it. It's so it sounds like kind of what you're seeing is that like having the crisis response plan, reasons for living, makes people feel a little bit better, and it almost makes the suicidal thinking less rid like more flexible and easier to kind of restructure and kind of more malleable to treatment.
Yeah,
Yeah.
ideally. I think one thing that separates crisis response planning from maybe other safety planning type interventions is we want folks to use CRP before the thoughts come about. Because it's a lot easier to use a CRP when you notice your warning signs of a crisis to like a crisis might like occurring in the like not so distant future or imminently, as opposed to when you're already in it. So if we're able to use that to like circumvent the crisis from happening in the first place, it's going to be a lot easier to use your skills. So that I think would be the biggest factor there.
Cool. Thank you. Any other questions for Lauren?
Oh, I see something in the chat. Were there other adaptations made besides adjustment mode to the sleep skills? Yes. So I say the good news is, it's good and bad news, is that participants are like, besides the sleep skills, they're like, the intervention's great. Don't change anything. Or I hate doing homework, which we can't change. You got to do homework. That's one of the essential ingredients of effective like interventions. Can't change that. But really, it absolutely like blew up one of my study aims, quite frankly. Participants like, we love it. This is great. Creators of BCBT loved that that was the case. But like the other adaptation was not to the intervention itself, but the ones that the participants like asked about. It was just a repository. I will say other things that I allow that the manual might be is a bit more rigid on, for lack of a better term. Are I'm allowing individuals can make their crisis response plan on something other than like a note card or written paper. Some individuals aren't able to write, so using something like a phone or a computer is allowed. I tell participants in DSPIRE, I don't care how you use your crisis response plan as long as you're able to access it. So yes, ideally, we have the idea of making it personalized and salient by writing is there. And if an individual isn't able to write, I still want them to have something. So we allow them to use note cards or their computers. as long as they're able to access the plan, the crisis response plan when they need it. Other skills adaptations that we did from the jump that we didn't ask for feedback on, and participants haven't given any additional feedback, or is there is another skill that does require writing something down called coping cards. Again, similar to the crisis response plan. Not every individual is able to access or write down things on a note card, or even see a note card if they write things down to begin with. So they are allowed to use whatever modality they want to create these types of reminders of things in treatment that work for them. Those are like the biggest things that are the biggest kind of adaptations. Otherwise, the participants have said they've really liked the treatment, like the telehealth modality. I think that's partly demonstrated by the really low attrition rate too. That participants like it, but again, that does make it a little difficult to test what if the changes actually improve the intervention, given that less changes have been made. But again, I think that's a good thing, though. It really speaks to the flexibility of the intervention. Other questions I can answer or thoughts?
Just kind of as a follow-up question, Lauren, can
Mhm.
you explain the difference between the coping card and the CRP?
Oh, yes, happy to. So crisis response plan is like individualized set of steps individuals can use to prevent themselves from getting into that suicidal mode or suicide like acute crisis, or if they're already in it, help calm themselves down. But ideally, they use it beforehand. A coping card, or in the study call it coping cues, is a way for an individual to cement the skill that they've already learned. For instance, they successfully challenge the belief that I'm a burden, using maybe one of their worksheets, but we want them to cement the skill and they really don't want to keep doing worksheets. So on one side of the card, individuals typically write the unhelpful thought, I'm a burden. On the other side, they write the new belief that they've developed or the alternative based on the work that they've done. So that would be an example of a coping card, and they can just flip over the card and review it multiple times a day. I usually pair it with some sort of activity that they already do, like every time you sit down for a meal, every time you check your email, something like that. You pick up your coping cards and or your coping cues and you view them. Could also be done to help target a behavior. So if an individual wants to get out of the house more, but they feel unmotivated, that could be the problem is on one side of the card or one part of whatever digital note they're using, the other side of the steps to target the problem. So step outside the house, go for a walk for 5 minutes, even if I don't feel like it. See how I'm feeling after 5 minutes. I can turn around and walk home if I, am done. Otherwise, keep going. Listen to music along the way. So things like that. That are really individualized to the patient to target whatever problem they want or whatever skill alternative or more helpful thought they want to solidify that they're already starting to believe themselves. Great question, Keeney. I see what else we have. Here is the evaluation of the study. Oh, thank you. What was the process for making the repository accessible to participants? Yes. Fantastic research assistants made that happen here. So what we did is we gathered feedback from participants themselves about what parts like weren't or not accessible. So sometimes the text boxes weren't working correctly. Also, we were able to just have two versions, a PDF version as well as the like a Word version of the document, and letting participants download whichever one they prefer, and knowing that that they can, for instance, that Word document, edit it whatever way they see fit to make it more accessible, like increase contrast, things like that. We also offer to do these things ourselves and email them to the participants as well. But basically, we created the website. And then we also tested each of these things too, using like screen readers. So I do like have a screen reader downloaded where I check these. Great questions. Any other questions or thoughts?
I always have questions.
If you got some, we got time. I mean,
Yeah, I'm really excited to hear about the responsive mechanism feedback design that you use. Can you tell us a bit more about like what that process looks like? So do they submit the feedback like online? Like where are these interviews? Like how did you acquire that feedback?
so I did have them submit forms online, looking like using the system usability scale, and like open-ended questions, like the effectiveness of treatment or treatment satisfaction questionnaire and like some open-ended questions. Looking back, I wish would have done qualitative interviews instead, to really get more fine-grained feedback. So that way, I think using online feedback can run the risk of participants just saying everything's fine, like not applicable, which did happen. So I, looking back, would not have done that. Would have done a qualitative interview as part of the process. It just is more um, burdensome for the participant to continue to do lots of qualitative interviews. That's why I tried to balance that. But anyway, I do collect that feedback at sessions 5, 10, and treatment completion. And based on that feedback, we comb through it and identify what are the areas that participants want changed. And we see, for instance, like during that in one of the initial phases of treatment, lots of people came back and said the sleep skills do not work, like, or they are not applicable to me. They don't really take into account people with like who have chronic pain, or people who struggle to get out of bed, or who are stuck in bed for a lot of the day. So we made those adjustments like based on that feedback, and then implemented that for the remainder of the study. But it is, yeah, self-report currently, like through our online form. Any other like questions about the design or any nitty-gritty about that? I'm happy to answer too.
Doesn't seem like we have further questions.
All right.
Um, And so, thank you so much, Lauren, for sharing your work with us. Very interesting stuff, and we're very excited to see what your results will be for your trial. And yeah, um, let's see, Julianne, do you have any other announcements, or uh, Macy, do you have anything you would like to say before we end the call today?
Just thank you so much, Lauren. That was great. I'm looking forward to digging into more of the articles you cited in your presentation too.
Wonderful.
Um,
Thank you.